all questions and comments. We'll hold all questions and comments until after the presentation, at which point the recording will be stopped and we will begin our discussion without the recording. So again, hello, everybody. Welcome to today's session of the 2025 Global Collaborative Series, Aligning Advanced Practice Nursing with Global Sustainable Development Goals. My name is Asia Nyopane, and I'm here at the Yale School of Nursing. This monthly event is made possible through the generous collaboration of our esteemed partner hosts, Dr. Janae Marie Stacchiarini, a professor and associate dean for global affairs and director of the Pan American Health Organization of the World Health Organization Collaborating Center at the University of Michigan School of Nursing, Dr. April Kapu, professor and associate dean for strategic partnerships and global affairs at Vanderbilt University School of Nursing, as well as Betsy Usher, also at the Vanderbilt School of Nursing, the assistant dean of alumni relations, and Dr. Megan Allen, a recent graduate from Yale School of Nursing, who actually worked on bringing the respective parties together. Thank you to our partners for their dedication and contributions to this initiative. Each month, this entire year, we have been taking turns hosting this important series, and we encourage everyone to stay engaged by registering for a December session. And we are starting this up again in a little bit of a slightly different format for the next calendar year. So please be on the lookout for that. So now it's my pleasure to introduce today's two speakers, our very own Yale School of Nursing faculty member, Dr. Michelle Telfer, and her longstanding collaborator and our collaborator here at the Yale School of Nursing in our office in Uganda, Dr. Rachel Zaslow. Dr. Michelle Telfer is a nurse midwife with over 20 years of experience, who is an associate professor at YSN, who also holds appointments at the Yale School of Medicine, as well as the Yale Institute of Global Health. Her research focuses on midwifery care models and global maternal newborn outcomes, including collaborations in Uganda to advance midwifery education and practice. Dr. Rachel Zaslow is a registered midwife with 20 years of experience in sub-Saharan Africa, who focuses on strengthening maternal health systems in resource-limited settings. As the executive director for Mother Health International, she develops culturally specific midwifery models and oversees a model birth center in northern Uganda with some of the best perinatal outcomes in East Africa. Please join me in giving a warm welcome to our two speakers as they share their expertise and collaborations in Uganda with us today. Thank you and welcome.
Thank you.
Thank you, Asia. So I'm going to start, and hopefully we're going to go back and forth, but thank you all for coming. We're really excited to present and share this work with you. So we're going to talk a bit about scaling up a community-directed midwifery model of care that improves perinatal outcomes. And so just to relate it back to the Sustainable Development Goals for this series, we're going to be focusing really on sustainable SDG 3, and this really it relates to better health for all people, but there is, the most vulnerable people really are mothers and newborns. And so one of the goals is to reduce maternal mortality globally to a ratio of under 70 per 100,000 live births. And for much of the global south, that's still pretty out of reach. In Uganda, it's around 350. And even here in the US, when we look at Black maternal mortality, it's over 70 in our own country. And then we also are looking towards ending preventable newborn and child deaths by 2030. And the most vulnerable of those are the newborns and neonates, so that's also where we're focusing. As well as with midwifery care, we're going to be looking at ensuring universal access to sexual and reproductive health care so that everybody has that access. So just to give a little background, we still have unacceptably high rates of maternal and neonatal mortality across the global south, despite recent investments, especially in the midwifery workforce. And about 10 years ago, the Lancet series on midwifery came out, and it provided this evidence-informed framework called the Quality Maternal and Newborn Care, or QMNC framework. And this basically what the series did, they took over 400 randomized controlled trials and did a synthesis of all the evidence. And what they found was, they created this framework which is what every mother and newborn needs to survive childbirth. And so they identified key quality components. And so we're going to talk a little bit about that. But what also came out of this is that if we implement this framework and have universal coverage of midwifery care, we can achieve over 80% of and avoid 80% of maternal and neonatal deaths and stillbirths, which is pretty dramatic. So we have this evidence that when fully educated, licensed, and integrated into interdisciplinary teams, which is key, we still need physicians, we need community health workers, we need nurses, nurse practitioners all along the continuum, and have a supportive environment, we can deliver about 90% of this care. So this is the framework, and I'm not going to go into great detail, but I do want to just sort of talk a little bit about some of the categories. And so we have practice categories, which includes education, health information, health promotion. We have assessment, screening, and care planning, and then promoting normal processes. If we go to the next level, it's looking at how care is organized. So is care in the community? Is it accessible to people? Are the services good quality? Do they have medications? And is the workforce that's there, are they competent and supported? Then you look at values, which is the blue box, and that includes respect. And respect and communication, and this includes community knowledge and understanding, or at least cultural humility that's tailored to each woman's circumstances and needs. And then the overriding philosophy, which is really rooted in midwifery, is optimizing biological, psychological, social, cultural processes, and really strengthening the birthing person or woman's capabilities and using expectant management, knowing when things are normal and not intervening, and only intervening when things kind of go off that path. And then the final bar here talks about the different practitioners who can combine clinical knowledge and skills with this interpersonal and cultural humility, and divide the roles and responsibilities based on need, competencies, and resources, right? So across most of the world, aside from the US, there's kind of a common phrase of everybody needs a midwife and some women need a doctor. Whereas in the US, we've kind of flipped that. And so the division of roles and responsibilities here in our country is not really optimized. Let me show you the next slide is, so everything in the red box, which is most of this framework, is the scope of midwifery practice. And it focuses essentially on promotion, promotion of healthy life and prevention of complications. And then this one tiny box way up in the corner, and this is where we have obstetricians, maternal fetal medicine, and neonatologists. And this is probably about 10 to 15% of the population of childbearing women and infants that will fall into this box. But by and large, it's really been the focus of funding and the attention, and that's where most things go on high-risk things instead of on prevention. So I'm going to transfer over to you, Rachel.
So while the Lancet series that Michelle has described was published in 2014 for the first time, and there have been many follow-up papers as a result, the World Health Organization this year published this position paper, and it is on transitioning to midwifery models of care. And what they have asked ministries of health around the world to do is to look specifically at the framework that Michelle has just described and implement it in their settings. There's enough evidence that this will radically reduce unnecessary death in childbirth, that it is now imperative to reach the SDG goals that we actually start to put it into practice. But that's not quite as easy as like, just make a little hop, skip, and a jump and do this, right? There's a lot of barriers in the way. So we're going to talk today about what some of those barriers are, what they look like, specifically in Uganda, where we work, and then what it looks like to implement an integrated model of midwifery model of care and what those outcomes look like. So these are some of the guiding principles of the midwifery model of care. At first glance, they seem like very obvious, right? we should all have human rights-based care. We should all have respectful care. We should all have high quality care. And we should have care that is coordinated by midwives, that is integrated and collaborative. These seem really simple, and yet what they all require are systems that work towards these goals. And so that can look different in every setting. So we asked the sort of question of what does it mean to integrate this model, right? The World Health Organization has said, hey, ministries of health, put this into action around the world. Everybody needs it. Everybody deserves it. It's a human right. We know that literally 90% of death in childbirth is preventable, and yet we can't do it somehow. So looking back, the majority of our ancestors, right? Probably every single person in this room had an ancestor at some point who was delivered at home with a midwife. And of course, we know that outcomes at that time, generations ago, were not very good because we lacked clinical care. But what we had at that time was a lot of care that was really community integrated. It was your neighbor. It was the person closest to you who really, really knew you and your needs. They knew if you were food insecure. They knew if you were experiencing domestic violence. They knew some of the social determinants of health, and they were able to tend to those. And what happened when we started professionalizing midwives into the nursing workforce is that we sort of removed that element of human-centered care. And what that framework shows that Michelle went over is that actually it requires everything. It requires clinical care, and it also requires deeply culturally specific care in order to achieve the outcomes that we need. And so we want to talk about what it looks like to do both. So many of you are probably familiar with the 3 delays. This was a paper that was published for the first time in 1994, which, you know, to some of us might seem like yesterday, but is actually quite a long time ago. And so this paper said that there are 3 major delays that if we addressed would lead to the prevention of about 90% of death in childbirth. So the first delay is a delay in a decision to seek care. What does that look like practically? If you look at this woman on the top, a lot of people who live in rural areas that are subsistence farmers live very far from a health center, and they live on what they grow. And so if you live on what you grow, it means you don't have a lot of cash. And so if you are out in your garden farming the food that you will eat that week, and you get a headache and you are 37 weeks pregnant, the resources that it would take to go get that headache checked out far exceed what the symptoms are, right? Even for those of us here in the US, if you get a headache, you're not necessarily calling your doctor right away. You're going to wait till it's serious. But if you don't have a phone, if you don't have a car, that first delay and the delay in the decision to seek care can really impact the next delay, which is the delay in reaching care once a decision has been made. So if you have a headache at 3 p.m. and you don't do anything about it, but at 10 p.m. it turns into an eclamptic seizure, and your road looks like where this vehicle is, it's washed out. There's nobody in your community who has a personal car. There's no ambulance. There's no phone to call. It can take you many, many hours to reach care. And so that delay is critical. And then the third delay is the delay in reaching care once a facility is reached. If when you reach a facility several hours after the eclamptic seizure and you find that there's no doctor on call at 4 a.m., or that the doctor is performing an emergency C-section and cannot tend to you until several hours later. The other issue might be that, a lot of hospitals experience stockouts of essential medicines. So maybe there's a midwife there who can tend to you, but there is no medication available to treat what is now preeclampsia. So all of these things lead to unnecessary death in childbirth, and they are real and they impact what kind of care people can get. So when we look at that framework, I want to keep referencing us back to that framework. We sort of have to ask, well, given these circumstances, how do we enact this kind of thing? Like, is it just a sort of dream that we could all reach that, or is there a way to enact it? And so that's the question that we want to pose. Like, can this midwifery model of care, which seems so lovely and is evidence-based, in fact, it is the only evidence-based way to radically reduce death in childbirth. Can it be achieved with so many, in settings with so many barriers to care? So right here, just these images, just to give you a visual, right? On the left is somebody at a hospital in Uganda in postpartum, and she's being checked in on by a student midwife. But there's a pad on the floor because there are no more beds for her. There are not midwives who can check her BP there, at regular intervals. There's nobody who's going to check her fundus. And it is just because there's not enough midwives. We have a severe midwife shortage. So when we talk about the need for continuity of care, that is part of it. And then on the right, we have somebody in labor, and this person in labor is laboring in a hall because there aren't enough beds for her. It means that there's not anybody who's, monitoring fetal heart tones. There's not one midwife who's tending to her, and there's nobody who understands her specific background. There's nobody who understands what it took for her to get there that day, how far she came, what her specific needs are. There's no electronic chart to understand, notes. There's maybe nobody who can look at if she had an ultrasound before. So we lack a continuity of care just because of the way that things are set up. So I worked in such a hospital 20 years ago in northern Uganda, and I saw a lot of unnecessary death in childbirth. And what I noticed, right, was that when we look at this framework for care, when we look at what every person needs and deserves to have a safe childbirth, what is missing in the hospital context is not necessarily clinical care. It's infrastructure issues, right? And it's also this element of cultural understanding and knowledge that is embedded in communities. And so some of it is workforce shortage. So what I started questioning was, well, what about those traditional midwives who, our great-grandmothers were delivered by, and who at that time, 80% of people in rural areas in northern Uganda were still going to, and yet they had been made illegal. And, for good reason, they should not be compared to licensed clinical providers, but it doesn't mean that there's no role for them. And so we started bringing them back in, and we started bringing back in traditional midwives in the role of community health workers. Community health workers are a pretty globally accepted role of non-clinically trained people who are embedded in communities that are there as helpers, as support systems, and to fill in some of the gaps when clinicians get overwhelmed. And so we formed a collective of about 60 community health workers who were trained specifically in maternal health care. And we built a birth center. The birth center that you see on the left is our birth center in northern Uganda. And it is for Uganda, fairly relatively low volume birth center. We have about 3 deliveries a day. A lot of hospitals have between 20 and 100 deliveries in a day. And so we're low volume for the region, but we focus specifically on one area and providing high quality, culturally specific and embedded care. And so what that looks like is community health workers working with their patients, the women in their communities who are pregnant, enrolling them in healthcare early, and then bringing them to our birth center where we have licensed nurse midwives and collaborating physicians to work alongside every single pregnant person and wrap around care, giving them all of those elements that you see in that framework. So I'll talk about what that looks like, but I'll also talk about some of our data. We've had about 21,000 deliveries. We've had 0 maternal deaths. So in those 21,000 deliveries, what that means when you look at what the maternal mortality is for the region, it means about 67 maternal lives have been saved since our inception. Our neonatal mortality is 11 out of 1,000 compared to 34 out of 1,000 for the region. And that is including our transfers. So that's including the high risk cases that we transfer who need C-sections or who need higher level NICU care. And so we have an average of 8 antenatal visits compared to 3 for the region. That means that we catch things earlier. That means that we are aware of what's going on and we're able to make care plans for patients. And then we have a 90% rate of birth at the facility with skilled nurse midwives. So this is very different than a lot of rural areas where 80% of deliveries are happening at home without a licensed provider. And so we flipped that on its head. And as such, we have changed the outcomes. And what that looks like is the best outcomes in the region that we know of. So we want to sort of show you visually the 3 delays on the left that we went through, and then the quality maternal newborn care framework on the far right. So on the right are the categories in the framework. On the left are the 3 delays. And in the center line here, we have the activities that the Mother Health International Birth Center does to address both implementation of the framework and addressing the barriers. So we have community health workers who are trusted, who are enrolled in our program, and they have phones that belong to the clinic. And so when a client goes into labor, all they have to do is get to their closest community health worker. And then we will pick them up in labor and bring the whole team to the health facility. The services are free to the community. We have community embedded fundraising structures to ensure that every single person has access to the care. We have a mobile midwives program. So the community health workers mobilize pregnant people in their communities and they say, hey, on Wednesday, nurse midwives are coming to our village to offer prenatal care. And we bring everything. We bring ultrasounds, we bring HIV testing, we bring essential medicines so that people can get the antenatal care that they need without having to trade something like getting water for the day for prenatal care. We have an ambulance service with a driver that's on call 24/7. So if we need to transfer to the hospital, the nearest hospital from us is 75 kilometers away. And so it takes over an hour to reach there. But if we didn't have an ambulance, it would take many, many more hours to organize care. So if we need a C-section, we know that we can call our collaborating physicians and we're about an hour away from care. We have highly trained nurse midwives. So when people come in labor, they are met by our nurse midwives, and then they work together collaboratively with the community health workers. And we ensure that our lab, our pharmacy, and our labor suites are fully stocked with essential medicines. So these are sort of the pillars of how we reach those good outcomes. It seems simple, but it's actually, we are the only place that we know of that is doing such a thing.
Great. So you've kind of gotten a brief introduction to the model that's at the birth center there. And you can see sort of from this, we have the mother and baby at the center with the easily accessed resourced clinic. We have the community health workers that know the community and the mothers. And these things can lead to these outcomes below if we follow the evidence in the Lancet series and implement that framework. The one thing we haven't really touched on yet that's pretty critical is the education of the licensed midwives. And so I want to spend a few minutes kind of talking about that a little bit. So one of the things that Rachel and I often talk about is we have this midwifery model of care, but then we have to kind of put that up alongside what nurse midwifery training and education looks like. And specifically in the context that we've been working is in Uganda, but it is fairly similar across much of sub-Saharan Africa, and that we can kind of abstract that to. So with Rachel and 2 of our Ugandan colleagues, Dr. Nalugo and Dr. Nabirye, both midwives and both doctorate midwives that work at Makerere University in Kampala, we did a review of the midwifery curriculum in Uganda and really looking at, what the core curriculum is. And what we found is that they have 4 different kind of cadres or levels of midwifery education. And there's over 70,000 licensed midwives within Uganda. However, the vast majority of those over 83% are licensed at the certificate level, which is the lowest level. And because it is expensive, it requires additional training and funds to reach the higher cadres. And it's also very difficult, which we probably don't have time to go into now, but there's a lot of barriers to kind of moving up the ladder in these cadres. And so your majority of these midwives have been trained in nursing, but then they've, after high school, and then they've completed really about a 6-week maternity nursing level course. They're not trained in complications or high risk, and they're not really meeting the standards that align with the International Confederation of Midwifery standards that they would be equipped to practice in one of these remote locations. And unfortunately, sort of the stark reality is a lot of these midwives are trained and then put out into very rural areas on their own, often in, a small community, in a remote community, and don't have easy access to support, to physicians, and they can have any kind of patient walk in, to them into their clinic and are not really well prepared to manage a lot of the complications. So we need to kind of differentiate sort of training more midwives versus training midwives that are competent in the midwifery model of care. And one of the gaps that we found is really there's not a strong midwifery mentorship model, and preceptorship training for midwives is very minimal. Often students are put onto a very busy labor ward. The midwives kind of will try to support them, but they're also, are also running and overwhelmed. And so there are not sort of outside preceptors or time for precepting. And so these are some of the key things that are missing. And then, like I said, it's not unique to Uganda. And so some of the things that we've found and discovered are applicable in other settings. So one of the things that we've been doing with our colleague, this is Dr. Scovia Mabalinda, who's the director of the Master's Midwifery at Makerere University, is bringing the Master's midwives. She had the first Master's Midwifery program in East Africa. There are now a couple more. So they make up less than 1% of the midwives in Uganda, but they are actually the next sort of leaders that can work to help to implement this change. Often they go on to high-level jobs in the Ministry of Health or within health systems. So they are kind of the next leaders. And so we've been bringing, for probably the last 7 years, I believe, their master's students up to the birth center, and we do kind of an immersion training. That's where they're doing their community health immersion. And many of these students have never been in very rural parts of the country before and have not kind of seen, even though many of these, they're all have been midwives for many years, they often work in urban settings and have not been in such a remote area. So they undergo this placement with us. We do a workshop based on the QMNC framework, which you can see we drew on the wall of the birth center. And we're really kind of showing them sort of introducing them to the framework, teaching them about physiologic birth and kind of low intervention and upright birth, and really talking about what this midwifery model is with continuity of care. And so I don't want to go too deep into sort of the parts of it, but here's one of the groups we had a couple years ago. We were working with them. They're in most labor wards in Uganda and many countries. They're just sort of high flat beds, as they can be in this country as well. There's not a lot of privacy. There's not a lot of kind of movement. And so we were working with them on learning how to support upright birth or different positions, and having them sit on the birth stool. How can they sit next to somebody and do that birth without having to bend over and hurt their back? And they were really so excited to be learning this and really excited to start to implement some of these simple things like doing a hip squeeze. And even if in a busy labor ward, there are things that they could then show a support person to do that would go a long way. So these are just some more pictures. So they spend about between 2 and 4 weeks at the birth center, and they do the outreach clinic with the midwives and the traditional midwives. They learn to sort of get to know the community. They are really spending a lot of time with the women and in the birth center, kind of learning this model. And then what we've started to do is to work with some of the graduates from the program on trying to start to implement this model in other places. And so that's where we've developed over the last 8 years that we've been working together, is sort of this birth care bundle that aims to address these issues. And while Rachel's birth center is phenomenal, it's taken her 20 years to kind of build that and transform that. And that's not really feasible, on a larger scale. We need something that's a little more nimble, that's quicker, that can address these key core issues. And so with this call from WHO on transforming the midwifery models of care, we came up sort of with this group of interventions that can be part of a QI, or a quality improvement program. And so it includes this grouping of didactic content, skills training, life-saving tools, some equipment such as fetal Dopplers, because most people, while you can listen with the Pinard, many people will just listen on admission, and then not, either they don't have time or there's only one Pinard horn for the whole ward. And if we can have Dopplers, it's a little more in training in that we're able to kind of do interventions more quickly before we get to a fetus that's in distress. So those are some of the key things. And it's really meant for us to be able to go into existing clinics, work with doing training of the staff, and kind of doing an assessment of what they have, and helping to support them in doing mentorship over time. So we have these three kind of main aims, which is co-creating this curriculum that addresses the midwifery model of care, but based on their own communities. So what their specific community needs are, and then using this model, but working alongside the health centers to help improve that. And then to have a longitudinal mentorship program. You can't kind of go in and do a training and then go out. We know that even in our own setting, that rarely works and sustain change. And so we have a 2-year mentorship program where one of the master's prepared midwives will work with the health center and that staff. Let's see. So Rachel's going to talk about sort of the program that we've started this past year. It's kind of ongoing, but she can talk a little bit about what it looks like on the ground.
So we are in the process of working with clinics that want to transform their care into the midwifery model of care. As Michelle said, midwives graduate with wonderful clinical skills, but they have never even heard of the midwifery model of care. And so then they go work in spaces and there's no way for them to implement it if they have no knowledge of it. So that the Transforming Birth Care Bundle is really aimed at close mentorship and helping clinics transform. And so we're using upright birth here as an example, but it's not all about upright birth, right? It's all about understanding how to give care, how to reach people when they don't come for prenatal care, right? How to manage when you have 50 people come for prenatal care and you're the only midwife on that day, and you're also responsible for the labor and delivery ward. How do you manage all of the patients? How do you give continuity of care? And so with close mentorship, we're really looking at, well, are there ways that we can actually work with community health workers right here, who can do some of the labor support? Are there ways that we can restructure how we do antenatal care so that high-risk moms are coming on one day and the moms who are coming for their first prenatal visit, which takes longer, are coming on another day when we have more midwives on staff? So simple restructures that help us to, work smarter, not harder, I guess. And so the basic principle is that the midwifery model of care can happen anywhere in any context, that training all the staff on key elements is really important. And then we help assess the space and figure out what we need, right? Maybe not every person can have their own private room, to deliver in, because that doesn't work in that space, but we can create curtained off areas. We can create quieter spaces. We can create spaces where when people go to walk in labor for upright birth, it's nice. It's maybe like we can create a door out to the garden space. So there's things we can do to transform any space, no matter what it is. The picture that you see here on the left is our midwife from Mother Health International, Monica. And Monica, so you see the bed behind her. I know it's kind of a small picture, but that's that very high up, very small delivery cot that's flat. This mom was having a very slow pushing phase and the baby needed to come out, and there was not a birth stool available. So she took 2 sets of stairs that are used for climbing up onto the bed because the bed's so high, and she turned one into a birth stool and the other into a stool for herself. And so what you see is her delivering a baby here using stairs. And the person behind her is the community health worker that has been integrated into the clinic setting. This is a facility that is not a Mother Health International facility, but we're helping to mentor. And so we're having a birth here that is a physiologic birth, that is supportive, that is helping the mom, and that is integrating the tools that we have. And that's essentially what the midwifery model of care is, right? At its core, the midwifery model of care is not one size fits all, but it's saying, what does this specific person need in order to have the best possible outcomes? Like if I were to put midwifery model of care into one sentence, that would be it. So that's what we're doing. Uh-oh. Okay, so this is a video that Michelle can play in a second. So, but not quite yet. I want to describe it before we hit play. So the video is of a birth that is happening at our birth center in northern Uganda. And you're not going to see anything specific. You're just going to see a little peek through the curtain, but you also will see a lot. So the person wanted to push. She was about 8 centimeters dilated, but feeling a lot of pressure. But the cervix was thick. And so the midwives were asking her not to push yet. And, you know, anybody who works in birth knows that that can be really hard. In a clinical setting in northern Uganda, normally what would happen in that instance is that she would just kind of be yelled at. Don't push, it's going to hurt your baby, right? But in this setting, we got her on the birth ball. So she's bouncing, she's upright. The person that's standing in front of her is her traditional midwife. So the person from her village who came with her. The person standing behind her is one of the master's students from Makerere University. She is a licensed midwife in the country. She's getting her master's in midwifery. And then the person next to her is the licensed midwife from MHI. And what they're doing in Acholi, the language that's spoken in the community, the traditional midwife is telling her, don't push yet, you're doing good, just breathe, just breathe. And then what the other midwives are doing is they're singing to her. And as they sing to her, it is calming her, right? It's allowing those labor hormones to kick in. It's allowing that oxytocin to flow through her body. It's allowing her the sensation of comfort and community that is helping her get through the next few contractions that hopefully are going to help dilate that cervix so that she can then move into the phase of pushing and having her baby. So this is really the integration of all of the things, right? And then surrounding that is, if this turned into an emergency, we have an ambulance standing by, we're going to get to higher level care, right? And so we have all of these layers in place to ensure that people have the best possible outcomes.
And I'll just say too, her child is alongside,
Yes.
because that's what you do.
Yep.
Uh-oh. Hold on.
I think you have to click it.
Yeah,
Whoa.
I'm trying. Now that we described this lovely thing, I'm clicking on and it just goes back.
Oh. I can try and pull it up if there are any questions.
Okay, because that's essentially the end, if we can show the movie. So do you want to why don't you try to pull it up?
Yeah, I'll
maybe
pull it up
get
and
out
then
of
we can, as a
prevention
YouTube
or
link.
something?
Yeah. Hold on.
I think it didn't come over, Rachel.
Yeah,
Oh,
it didn't come over. I'll just send you the link, or hold on.
okay.
Well, thank you.
Let me stop sharing, and then when we get the video pulled up, we will share that.
Right. Well, while we pull up the video, Michelle and Rachel, should we ask for any questions?
Yes, please. Yep.
Right. Okay. And we're going to stop the recording. I think Betsy and April, if you're able to do that. Hold on 1 second.